How accurate is thoracic outlet syndrome testing? Thoracic outlet syndrome has been controversial since its discovery in the 19th century and categorization as a syndrome in the 1950s. TOS represents a complex of symptoms based on whether there is neurovascular and specifically arterial versus venous involvement. It's complicated by the number of offending structures causing compression, which include a cervical rib, anterior scalene, costoclavicular space, or pectoralis minor. And to add another layer of complexity, this may be a dynamic, positional, therefore transient compression. So clearly, testing inherently will be difficult, first to detect TOS and then the site of involvement. As we all know, there are a number of named tests taught and utilized, yet what do we know about the accuracy and therefore clinical utility of those tests? A recent study attempts to gather what is known through a systematic review of high-quality studies. Before we discuss thoracic outlet testing, let's discuss the complexity of the clinical evaluation and research determining its value. When a patient's complaint appears to be neuromusculoskeletal, clinicians rely first on what the patient describes. Is it trauma, overuse, or insidious onset? And secondly, on what can be provoked or relieved on clinical testing. If musculoskeletal, this would include provocation or relief of pain, and the detection of deficits in function if neural. Clinicians assume that what they do is evidence-based because it was taught to them during their education and perhaps taught for decades, or perhaps because it appears on a form required by a healthcare organization. Yet until recently, most tests were often only based on a rational description of the relationship between the test and the suspected condition, the underlying mechanism of cause, and therefore detection with examination is almost always stretch or compression for nerves and stretch, contraction, and tenderness if muscular. However, when tests have been tested, the results have been markedly disappointing. Many tests as standalones are of little value. Clustering of tests seems to be of more value, but only if all tests are positive or negative for that cluster. A secondary complication is what is the comparative gold standard for the diagnosis, meaning is there a reference test that has been tested and shown to be either highly sensitive or specific? This all reflects the validity of the test. And finally, has the test been tested for reliability, meaning if other examiners, or even the same examiner blinded, were to test a given patient, are the results consistent? Again, disappointingly, most tests have not been tested for reliability, or when they have, are not shown to be very consistently reliable. Well, back to the gold standard. Dependent on the condition, what if you have no gold standard? Which in most cases means the pathology is not directly visible, or in the case of lab testing, detectable. Then you have to move to construct validity, which involves measuring the assumed effect of that condition. A common example is pulmonary functional testing, such as forced expiratory volume in 1 second for asthma. And to the final layer of complexity, the different statistical perspectives on the accuracy of the test being tested. In simple terms, sensitivity and specificity evaluate the ability to detect true positives and negatives, respectively, without consideration of the prevalence for the number of individuals with the disorder in the study population. Positive and negative predictive values do the same, but are sensitive to the prevalence of those with the disorder. And then finally, likelihood ratios, which allow translation of the post-test predictability based on the prevalence or pretest probability of the disorder in the context of the clinician evaluating the patient sitting in front of them. All this seems daunting without context, so be patient and we will apply this in our discussion later. Needless to say, diagnosis is not a simple equation of A plus B equals C. And the last wrinkle in the diagnosis conundrum, let's imagine that there is no agreement on what the disorder is. Then one must question the successes or failures of treatment for that designated diagnostic condition. Of course, we should be used to this with the concept of subluxation. Now we could discuss thoracic outlet syndrome. As a rare but potential cause of neck and arm complaints, it's important to first consider the differential list. These include radiculopathy, referred pain from spinal structures, referred pain from trigger points, brachial neuritis or Parsonage-Turner syndrome, visceral referral, and shoulder instability. Why shoulder instability? Well, studies have shown that those treated with shoulder stabilizing surgery have had their TOS symptoms resolve. And to the prevalence of TOS in the general population, it's estimated to be only 0.01%. Now to the study. The title is Diagnostic Accuracy of Clinical Tests for Neurogenic and Vascular Thoracic Outlet Syndrome, a systematic review published in JMPT in 2018. Let's review types of compression. Either it's the brachial plexus resulting in neurogenic TOS, the subclavian artery resulting in arterial TOS, the subclavian vein resulting in venous TOS, and the vast majority of nonspecific types of TOS, sometimes referred to as disputed neurogenic TOS. Unfortunately, nonspecific TOS with neurologic symptoms accounts for over 90% of all TOS surgeries in the United States. Why? Because it's difficult to pinpoint on clinical exam and, when unresponsive, moves on to imaging and surgical investigation and repair. In fact, for disputed neurogenic TOS, the authors state that, quote, as a consequence, many patients with TOS symptoms may present with minimal sensory deficits and lack demonstrable muscle weakness. Owing to the lack of accepted criteria for the diagnosis of TOS, test results may be unable to confirm or rule out the presence of the syndrome, unquote. Signs and symptoms should reflect what is compressed. Neurogenic should result in paresthesias, numbness, tingling, weakness, loss of dexterity, pain, or atrophy, and arterial should result in ischemia, pallor, coldness, fatigability, pain, muscle cramping, and absence of pulse. And if the compression is venous, this may result in edema, cyanosis, fatigability, heaviness, and thrombosis. One more layer of complexity is that positives on clinical testing can be interpreted as positive if they reproduce symptoms and/or if they result in a decreased or absent radial pulse. So we know what can be compressed. The next question is, where is it compressed? There are 4 general possibilities, including a cervical rib, anterior scalene, costoclavicular space, and the pectoralis minor muscle. A point about cervical ribs: this is an elongated C7 transverse process found in about 5% of the population. However, only 10% of those individuals develop signs and symptoms. Although there are many TOS tests, index tests evaluated in this study were Adson's tests and modified Adson's or Halstead's tests and Allen's tests for compression at either the interscalene triangle or costoclavicular space, and Roux or East test for compression at the thoracic outlet, and hyperabduction or Wright's test for compression at the pectoralis minor. Included studies were those that compared physical examination findings to one or more of the primary diagnostic tools. That would be either MRI, CT or angiography, Doppler, neurography, or electrophysiologic testing. Here are some examples. In the upper left, we see MRI demonstrating subclavius involvement for costoclavicular compression, angiography demonstrating decreased flow on the right side, and on the bottom left, an X-ray demonstrating a cervical rib. The results of the literature search were out of 3,932 studies, only 10 were eligible, and when risk of bias was considered, that left only 4. For the 10 eligible studies, the researchers used the Quadus 2 tool to evaluate 2 dimensions, risk of bias and applicability concerns. This resulted in the elimination of 6. One study by Demerbag et al. Had a low risk of bias. 3 studies, 2 by Demondian and Panegyris, had an unclear risk of bias. Even in the 4 included studies, there were huge variations in testing comparisons. Only one study by Demerbag et al. Reported a positive Roux index test for all patients and a negative Roux for all controls at baseline. Among the 4 admissible studies, none of the articles compared the same index test with a positive test result in all their patients. The criteria for patient inclusion in both de Demondian et al. Studies was 2 positive tests out of 4 or 5 index tests. However, authors failed to specify which one of these tests were positive. Furthermore, these studies did not report positive or negative findings of index tests in the control group. For subclavian artery functional stenosis occurring on provocative positioning, neurovascular compression was more common in the costoclavicular space. Venous compression was frequently observed in all 3 thoracic outlet regions in the healthy group. In one study, of the 19 patients with a diagnosis of subclavian artery stenosis on Doppler, 7 had a normal subclavian artery on MRI. MRI, therefore, appears to be the reference standard to confirm a diagnosis of TOS because it can evaluate the neurovascular bundle of the thoracic outlet in different arm positions. And for MRI, for the provocative position at the costoclavicular space, overall, for the patient group, it showed that 22.9% were arterial, 52.3% venous, and 12.1% neural. But for the control group, 1.4% were arterial and 41.7% were venous. The high sensitivity and specificity for neurovascular compressions were found in the costoclavicular region during provocative positioning on MRI. There are important limitations of the study results. Although abduction of the arm was used as a provocative position during MRI and Doppler in 3 studies, the sensitivity and specificity values for the hyperabduction clinical tests were low in 2 studies. In addition, the diagnosis of venous TOS appears to have low validity. Venous compression was frequently observed in healthy volunteers during provocative positioning on MRI. Arterial compression was more frequent in the provocative position when considering the percentage of neural and arterial compression on MRI for any type of TOS presentation. So in summary, the studies had more value in determining if special imaging is accurate in detecting TOS in symptomatic patients. However, the studies did little in confirming which index tests are of value. Sensitivity and specificity were calculated for the imaging, but not for the clinical tests they were compared to. So where do these findings leave us clinically? Seems there's little to guide us. Well, let me suggest a valuable source. This and a couple of other texts have taken on the daunting task of evaluating all the diagnostic testing literature and summarizing in one source. This textbook, Orthopedic Physical Examination Tests, an Evidence-Based Approach by Cook and Hedges, is probably the most valuable. Let's take TOS testing as an example. Here we see a summary of individual test values reflecting sensitivity, specificity, and positive and negative likelihood ratios. Without knowing any more than the following, we should get a clear idea of the picture here. Sensitivity and specificity levels should be high as a percentage. The closer to 100%, the better. That's easy. For likelihood ratios, a little more to know. A positive likelihood ratio of 10 changes the probability of the condition with a positive test result by about 45%, whereas a negative likelihood ratio of 0.1 changes the probability of the patient not having the disorder with a test that's negative by 45%. So scan this table and you'll find that none of the values are convincing. Translation: no single test is of diagnostic value in ruling in or ruling out TOS. Well, remember at the beginning we said that sensitivity and specificity are not sensitive to how many people in the study have the condition being tested for. Positive and negative predictive values do, but clearly none of the studies evaluated that, or if they did not report these findings. The bias may be that if many individuals had TOS, this may falsely elevate the perception of the value of the sensitivity and specificity. A solution may be to utilize the clinical prediction guide approach suggested from the following study, which appears also in the Cook text. Diagnosing thoracic outlet syndrome, contribution of provocative tests, ultrasonography, electrophysiology, and helical computed tomography in 48 patients, published in Joint, Bone, and Spine in 2001. The study by Gillard et al. Found that by combining 5 tests, positive responses on all 5 tests results in the following: sensitivity of 84% and specificity of 84%, a positive likelihood ratio of 5.3, and a negative likelihood ratio of 0.19. What are the 5 tests? Wright's, Adson's, hyperabduction, Roux, and Tennell's. So we're left with, how do you approach a patient? For patients with a complaint of neck pain and associated arm complaints, including any of the following: paresthesias, coldness, numbness, swelling, or weakness, the following may be an appropriate approach. First, a red flag check for concomitant visceral symptoms. If negative, distinguish with neurological testing to determine radiculopathy or peripheral neuropathy. If negative, next evaluate for TOS generally using the 5 index tests. If negative, consider sclerotogenous referral from the spine or trigger points. However, if general TOS is positive, attempt to localize to an area with tests to determine muscle tightness, for example, for the scalenes and the pec minor. Remember, the condition is rare, and the definition and criteria for the nonspecific form of TOS makes a firm diagnosis literally impossible. If your level of suspicion is high and you have indirect indicators of tightness in specific structures and postural reflections of that tightness, it makes sense to attempt a trial of care to determine responsiveness.